I would like to thank the organizers for inviting me to this exciting meeting. I continue the session by positioning JAK inhibitors in the IBD management. The outline of my talk is below. I want to first show you the biological significance of Janus kinase or JAK and signal transducer and activator of transcription or STAT pathway. This is a mouthful, just call it JAK-STAT pathway. Then I want to show you the efficacy and adverse events of tofacitinib in the therapy in ulcerative colitis. I will not show you anything about Crohn's disease because the phase 2 studies of tofacitinib in Crohn's disease were negative, so we don't need to talk about that. And then at the end, I want to position tofacitinib in the treatment algorithm in ulcerative colitis and show you some new data about JAK inhibitors in the pipeline. First, the JAK-STAT pathway. It's quite an important pathway in our body. It plays a role in regulating cellular proliferation, differentiation, and immune cell function. It's quite simple on this chart, but I'll show you later on it's a little bit more complicated. If a cytokine binds to the cytokine receptor, JAK is activated by phosphorylation and then activates STAT. STAT translocate in the nucleus and then activates their transcription factors such as NF-kappa B and IL-1 and TNF. And from there, the pro-inflammatory cascade starts, but as well other cascade starts, which contributes to cellular proliferation and differentiation. If you block this pathway, for example, with tofacitinib, it blocks the phosphorylation of JAK, and thus it blocks the activation of the STAT pathway, and the inflammation will not take place. Here you see a little bit more the complex features of this JAK-STAT pathway. In total, we have 4 known JAK receptors, JAK1, 2, 3, and TYK2, and we have 7 STATs, 1 to 7, and they play together and they have different function, as you see on the right chart. Tofacitinib is a pan-JAK inhibitor, so it inhibits all of the receptors above, all the JAK activation. However, in the future, we're looking at more JAK-specific blockade, such as JAK1 blockade, which then would, for example, exclude JAK2 and JAK3 blockade, and especially JAK2 is important in the hematopoiesis, and thus it could have an advantage in the setting of a side effect profile, and the specificity for JAK could as well have an advantage in the blockade of more pro-inflammatory functions of this pathway. Tofacitinib has been approved since now nearly 2 years, and the landmark trials were published in 2017, showing clearly an advantage in induction compared to placebo. There were 2 trials, Octave 1 and Octave 2. The data were comparable between placebo and tofacitinib. This was 10 milligram twice daily. Interestingly, there was no difference between biologic naive versus biologic experienced patient for clinical remission or response, and that's an important feature. The maintenance study showed as well an impressive difference between tofacitinib 5 milligram BID or 10 milligram BID compared to placebo in maintaining remission. And the delta were 23 and 29%, which is pretty impressive. However, if you have a good drug, you have to look at side effects. And side effects occur with this drug, and these are the main common side effects seen in the phase 3 study program. About 20 to 30% of patients have an elevated cholesterol, LDL, and HDL levels. In about 10% of patients, we find an increased blood creatine kinase. However, this is, so far as we know, not of clinical significance. We find an increased risk of herpes zoster, and we come to that later on, and an increased occurrence of nasopharyngitis. This year's DDW presented follow-up data for nearly 6 years of the whole phase 3 study program with nearly 1,000 patients and more than 2,000 years of total patient follow-up. You see again in this chart that there is an increased herpes zoster incidence for tofacitinib 10 milligram BID, a little bit higher, that's blue, compared to 5 milligram BID. And you have increased serious infections, again, 10 a little bit higher than 5. And but you didn't have serious herpes zoster infections. You didn't have a significant increase in opportunistic infections. There were some GI perforation, but across the board, it was not significant, and there were no increased MACE, major cardiac side effects. And we come to that later. Interestingly, the majority of the patients were on tofacitinib 10 milligram BID in the open label program. So essentially 80% were on it. So there are not many data about the 5 milligram BID long-term program because there are just a few patients in it. So what is the risk of herpes zoster and treatment-associated risks in IBD? If we look at this, we have to look first at the whole IBD patient group. And in all IBD patients, we find an increased risk of approximately twofold compared to the general population for the occurrence for zoster. The risk increases with age. Above 50 years of age, you can be considered as a high-risk factor patient. If you have a history of shingles, that puts you at a higher risk. And if you're Asian race, and that might be a genetic background. Now you have to see the occurrence of zoster with tofacitinib as well in context with other drugs. So if you look at tofacitinib in all registry studies, the risk was twofold increased for the low dose and sixfold increased for the high dose. The risk increased not over time, and the risk is reduced when the dose was lowered from 10 to 5 milligram BID. There was a higher risk of zoster in patients who were older than 65 years, if they had diabetes or if they were of Asian race. If you compare this now with other drugs, if you put a patient on steroids, the risk of zoster is increased by 2 to 3-fold, so similar like to the low dose of tofacitinib. If you put them on thiopurines, the increased risk is 3-fold. Only for the monotherapy with anti-TNF, ustekinumab, vedolizumab, and methotrexate, there's no increased risk for zoster described. What's about the major cardiovascular events or MACE in patients on tofacitinib? And this was essentially a very important news approximately 1 year ago in a group of patients treated in a 3B4 trial with rheumatoid arthritis. And the trial evaluated the long-term risk of MACE and malignancy in patients with RA treated with 10 milligram tofacitinib BID, 5 milligram tofacitinib BID, or anti-TNF agents. And the anti-TNF agents were mainly etanercept and some patients on adalimumab. There were over 4,000 patients enrolled. They were all older than 50 years of age. They had a diagnosis of RA and at least one cardiovascular risk factor, and they were on a stable dose of methotrexate while being on tofacitinib. And if you now see the incidence ratios for pulmonary embolism and deep vein thrombosis in the table below, it increases from anti-TNF, there's the lowest incidence, to 5 milligram BID tofa, and then as highest with 10 milligram BID tofacitinib. So it's a dose-dependent increase of the incidence of both. And that led the DSMB in the study to the conclusion that they have to stop 10 milligram BID. All patients were reduced to 5 milligram BID. And the final report of the study is still not out because the study is ongoing. It's a long-term study. However, the FDA and the European regulatory agency drew the conclusion and published a new black box warning with tofacitinib. And important is, at least in US, they changed the label that it was only indicated after inadequate response or intolerance of an anti-TNF agents. This is not really understandable. It didn't happen in Europe. Why should you first fail an anti-TNF before you're allowed on tofacitinib? Because that doesn't make sense in the setting of ulcerative colitis, at least. Because if you fail vedolizumab, you should be as well a candidate for tofacitinib, and not only if you fail an anti-TNF agent. I agree with the second-line therapy, but I don't agree with the designation of an anti-TNF agent. Additionally, they recommended maintenance therapy only at 5 milligram BID. If you need 10 milligram BID, should be only considered short-term and after evaluation of risk-benefit ratio. And they required a stop of tofacitinib if no response after 16 weeks. Since then, more data came out, and this was just published showing the major cardiovascular events or MACE in different tofacitinib drug development programs and as well in real-world experience. All patients these are all patients with RA. Here you see again the red box is a study which I just reported. You see the dose-dependent increase of the DVT and PE risk. 5 milligram is green and 10 milligram is blue. However, if you look at all the other programs, there was an increased risk and you had cardiovascular risk factors or VTE risk factors, but there was no dose dependency. Interestingly as well is this ENTRACT study, which compared etanercept and tocilizumab for the MACE side effects. And here etanercept has an incidence ratio which is nearly the same as the tofacitinib incidence ratio. So perhaps in this trial A3921, etc., the TNF was slightly too low compared to the ENTRACT study, and that's why you saw this dose-dependent increase. Interestingly as well, the real-world corona cohort overall did not show a significant risk difference of PE risk for tofacitinib compared to DMARDs. So again, we didn't find in all other study a dose-dependent increase of PE or DVT risk, only in this one study which is not fully published yet. So now it's important to look at the incidence of MACE in patients with ulcerative colitis on tofacitinib, and this is an update of the development program as of May 2019, and it was presented this year at Sanborn by Sanborn et al. At DDW 2020. First, you have to know that there's a general increased risk of DVT and PE if you have ulcerative colitis. This is sort of like in the range what we saw as well in the tofacitinib program. And if you look now at the induction maintenance cohort, there were 2 DVTs and 2 PEs, and each occurred in the placebo group. Only in the overall cohort, which include the open label extension, we had 4 PEs and 1 DVT. All patients were on 10 milligram BID, but I would like to remind you that more than 80% in this program are on 10 milligram BID, and all patients had risk factors for PE. So I think it's still open why this PE and DVT occurs, and if it's really increased is it only by tofacitinib, or are there other factors involved which play a role? Due to all the safety concerns as well as the risk of leukopenia, we generally recommend, and the FDA recommends this as well, laboratory monitoring of tofacitinib therapy. So at initiation, you should do a CBC and differential as well as liver enzyme. You can check the lipids, but that is, according to the recommendation, only meaningful after 4 to 8 weeks to see if there's a significant elevation. Some of my colleagues already do it at initiation to see if there is an elevation from the get-go, but the lipids should be checked after 4 to 8 weeks. Like I said, 20 to 30% have an elevation of HDL and LDL as well as total cholesterol. And then you should check every 3 months CBC differential and liver enzymes. As with anti-TNF and all the other biologics, you should rule out active or latent TB and hepatitis B at initiation. You should avoid initiation of tofacitinib if the lymphocyte count is below 500 cells per ml, or if your absolute neutrophil count is below 1,000. You should not start if the hemoglobin is below 9 grams per deciliter. However, there was no signal in the clinical trials that a significant anemia occurred. This is mainly because tofacitinib blocks the JAK2 pathway, which is involved in the hematopoiesis. And you should not start tofacitinib if there's severe hepatic impairment, because it's metabolized by the liver, and you increase significantly the tofacitinib levels if you have hepatic impairment. For every patient above 50 years, you should perform shingles vaccination with Shingrix. Unfortunately, it's not approved for patients below 50 years. Studies are currently ongoing, and hopefully we can soon legally vaccinate patients below 50 years. I do it in some of my younger patients, but often it's not covered by insurance, who decline the coverage because the patient is not older than 50 years. So how we position tofacitinib in ulcerative colitis? We know it's approved only as second-line therapy after exposure to anti-TNF agents, so we have to look what is comparable here. And comparable is vedolizumab, tofacitinib, and ustekinumab. In this table, you see the results of the induction trials and with clinical remission at week 8. And clearly there for vedolizumab, you see less efficacy in the previous anti-TNF exposed patient. It decreased by 10%. However, this is not the case for tofacitinib. And interesting, in ustekinumab trial, there were nearly 100%, 98.8% of the study population already exposed to more than one anti-TNF, and the delta in efficacy was similar to tofacitinib. This led the AGA to recommend that the induction therapy after anti-TNF failure should be done mainly by ustekinumab or tofacitinib, and vedolizumab is less preferred due to this data. If you look at the odds ratio for this, this is a little bit different presentation of the data. You see that tofacitinib and ustekinumab have high odds ratio inducing clinical and endoscopic remission. If you second row, if you compare this to vedolizumab, they're better than vedolizumab. However, they're not better than each other. So ustekinumab seems to be equal to tofacitinib. So that's the current recommendation. So if you then consider the decision-making for tofacitinib versus ustekinumab, you have to look at the advantages of tofacitinib. It's a fast onset of response. This has been published. The onset of response can occur as early after 2 to 3 days after initiation of therapy. It's an oral administration. It's rapidly absorbed. It has a very short serum half-life. So if you stop it, it's out of your system in about 24 to 36 hours. There's no immunogenicity because it's a small molecule, can be stopped and restarted. The advantage of ustekinumab are that it has an excellent safety profile, including it's considered safe in pregnancy and breastfeeding. The disadvantage of tofacitinib, we talk again of safety, it has an increased risk of infection, especially pneumonia and zoster. You need regular lab monitoring. It has a not yet well-defined cardiovascular risk profile for PNE and DVT for ulcerative colitis. I showed you the data, and it's currently not recommended for pregnancy or breastfeeding. The disadvantage of ustekinumab is, that's my personal impression, it's a slower response. There's no side-to-side comparison of tofacitinib and ustekinumab, but I feel it's a little bit slower. It is an intravenous and subcutaneous injection that can sometimes cause problems with insurance approval, and perhaps patients don't like that so much. It has the potential of antibody development, but that risk over is low, and it has a long serum half-life, but again, it's relatively safe. In my practice, and this includes as well anti-TNF naive patients, patients above age 65, I consider first-line vedolizumab or ustekinumab. In inpatients, it's infliximab or cyclosporin followed by vedolizumab. If you have a significant cancer history or lymphoma history, it's vedolizumab or ustekinumab. In pregnancy, you have a whole choice, but tofacitinib is not approved, so it's not in this choice. If you have steroid-responsive mild to moderate disease, it's a thiopurine. It's still a cheap option, I think, and you can do it in some patients. If you have arthritis, anti-TNF and tofacitinib after anti-TNF failure is preferred. And as we had it before, if you had previous anti-TNF failure, it's tofacitinib after consideration of safety aspects. And if you have a need for fast response, or ustekinumab. What's in the pipeline? There are many drugs in the pipeline. They're all more specific than tofacitinib, and I don't want to go through this list, but I just want to show you filgotinib. This was just published as a press release, and here I show this in context with the tofacitinib data. Filgotinib was an induction and maintenance trial similar to tofacitinib, the selection trial. If you look again at the delta, it seems to be pretty similar to tofacitinib. It's not better. If at all, it's slightly worse if you had previous anti-TNF exposure. So that means more specific inhibition via JAK1 might have less efficacy in this patient population. If you look at the maintenance of clinical remission, the 200 milligram maintenance had the same delta to placebo compared to the tofacitinib doses. However, if you had just 100 milligram BID, it was lower, but it's 10% difference. So that seems to be inferior. And I guess we need to use filgotinib at the time 200 milligram dose as maintenance treatment. The safety was not directly reported. The press release said the safety signals were equal across each group. There seemed to be a slightly higher incidence of Zoster, perhaps. There was no increased risk of PE, but we have to wait for the full publication. So in conclusion, tofacitinib in the moment is a second-line therapy for ulcerative colitis after failure of anti-TNF therapy. Tofacitinib and ustekinumab appear to have a high efficacy in anti-TNF experienced patients compared to vedolizumab. The choice between both depends on clinical presentation, patient preference, including insurance preference, and individual safety assessment. The risk of thromboembolism in TOFA patient still needs further analysis. Is this a drug or a class effect? Is this a dose effect? I show the data. And the future of JAK treatment is really interesting and exciting, and we have to see if JAK1 or if specific JAK2/3 inhibitors are more efficacious than tofacitinib and if they are more safe. Thank you so much.